Hi everyone, I'm Sarah. Hi everyone, I'm Sarah Klein. I am the Health Equity Alliance Coordinator with Health and Welfare Council of Long Island. And this is also my first meeting, so I'm excited to be here as well.
Hi everybody. I'm Nicole Russell. I'm the Chief Patient Experience Officer at Stony Brook Medicine. Nice to see you all in person and virtually. And I am co-chairing our Health Equity Steering Committee with Dr. Judy Brown-Clark from the university, our Chief Diversity Officer. So excited to be here to learn more and talk to all of you.
Great.
My name is Harriet Gordine Adams. Good morning, everyone. I oversee a Medicaid case management program with Project Safety Net New York.
Good morning, everyone. Wendy Darwell. I'm the president and CEO of the Suburban Hospital Alliance, which includes the Nassau-Suffolk Hospital Council here on Long Island and the Normet Hospital Association, which is the regional hospital association for the 7 counties north of New York City.
Good morning, everyone. My name is Brooke Oliveri. I'm the manager of the Long Island Health Collaborative and the manager of communications, health outreach, and research for the Nassau-Suffolk Hospital Council.
Good morning, everyone. I introduced myself already, but I'll introduce again. Janine Logan, Director of the Long Island Health Collaborative and Vice President of Communications and Population Health for the Nassau-Suffolk Hospital Council. Good morning, which is part of Suburban Hospital Alliance.
Good morning, my name is Amy Fleischer. I'm the Development Director for Long Island FQHC.
Good morning, my name is Kelly DeVito from Horizons Counseling and Education Center. We are an outpatient substance use program located on Main Street in Smithtown.
And I'm Maggie McWilliam. I'm also from Horizons Counseling and Education Center.
I'm Janet Romeo. I'm Assistant Director of Epilepsy Services for the Epilepsy Foundation of Long Island, which is also part of EPIC Long Island, which has residential programs and mental health programs for people with or without developmental disabilities.
Hi, good morning. Erica Clark from Stony Brook University Hospital, Community Relations Representative.
Hello, good morning. My name is Kimona Tracy. I'm the Director of Community Education Outreach and Health Benefit at NYU Langone. I'm happy to be here again.
Hi, good morning, everyone. I'm Paula Fries. I'm from the Association for Mental Health and Wellness. I'm the COO. Really happy to be back in person. We've been longtime partners with Health Collaborative and really excited to be back. And, you know, mental health, behavioral health.
Took a beating.
We're still taking
it.
Yeah, but I think if anything came out of this pandemic is people recognize it. And that's actually an unintended consequence.
Yes.
Thank you.
And those who are on the call, if you could unmute yourself, how shall we do this? We will start with, I can't see names, so.
Let me have Brooke call him out because she can see the names.
So Erica, if you would like to unmute and introduce yourself, please.
Sure. Good morning, everyone. My name is Erica Peralta. I am Advisor of Operations for the Community and Population Health Team at Northwell Health, and it's a pleasure to be here with all of you.
Thank you for joining us. Jackie?
Good morning, everyone. I'm Jackie Grimaldi. I work for Stony Brook Cancer Center, Community Outreach and Engagement Office as a health educator.
Excellent. Lori?
Good morning. I'm Lori Andrade, the Chief Operations Officer of the Health and Welfare Council of Long Island. We lead the Health Equity Alliance of Long Island, which is positioning to be the social determinant of health network for the 1115 waiver. Good morning. Nice to be with you all.
Thank you. Sloan?
Morning, can you hear me?
Yes, we can hear you.
Great. My name is Sloan. I'm the Injury Prevention Coordinator over at Nassau University Medical Center. We're a level 1 trauma center, and I offer a whole bunch of evidence-based safety programs throughout the community. Main things we focus on are evidence-based fall programs, followed by like distracted driving, pedestrian safety, and a Stop the Bleed initiative. Happy to be here today.
Thank you. Alicia?
She put in the chat she doesn't have audio.
Okay.
Thank you for bringing that to our attention. John? All right, we can skip John for now. If you'd like to jump in later, that's fine. Kat?
Can you hear me?
Yes.
Okay, I think that's me. I also didn't have audio on my computer, so I'm on my phone, but this is Kathy Emmett from Island Harvest Food Bank, and I'm the nutrition program supervisor here.
Nice to meet you.
Thank you.
Sure.
And Sophia?
Hi, everyone. I'm Sofia Flores. I'm the Spark Project Director at Stony Brook. We do HIV care for women and youth, but I work with the whole team in infectious disease here at Stony Brook.
Nice to meet you. And we have a couple of guests who are behind me, so you can introduce yourself. You can stand up so the camera can catch you.
Hi, I'm Sarah Hennis. I'm from the Suffolk County Department of Health. How are you? So nice to meet you.
Hi, I'm Nahid Khan. I'm from Nassau Community College. I'm the acting assistant dean for workforce development. Nice to meet you.
How you doing? Gary John Perkins here. Is anybody else having difficulty hearing? It seems like there's a lot of static on the line.
It is sorted.
I can't speak for anyone else on the call. Is anyone else experiencing that via Zoom?
Nothing on my end.
Mine for me as well.
John, we could hear you.
Yes. Loud and clear.
Okay.
Look, we're going to mute all the participants for now so that if there is any background noise, it'll be eliminated. Okay? I think that works, right? Well, this is a great, great crowd. We have County Department of Health, local County Department of Health represented. We've got hospitals and lots of community-based organizations, FQHC, long-term care. You work in the home care industry. I mean, it's a great, this is what the collaborative is about, right? It brings together these diverse partners, mental health, hospital, brings together these diverse partners because we've learned, and we knew this even before the pandemic, right? That collective impact model working together, there's a much greater strength in numbers. And we all continue to work on that same common goal of reducing chronic disease and attending to mental health issues and substance misuse issues. We want to bring those numbers down as well on Long Island. So it's great to see everyone here. It's great to hear and see everyone on the phone. This is a new technology that we're testing out today. I think this is the first hybrid meeting with this technology. So bear with us if we get a little confused ourselves. There's a couple of different control panels in front of us, but I think it's going to work out just fine. As I said, this is the first in-person, well, first hybrid and in-person meeting in a while for the Long Island Health Collaborative. And we have a fantastic person to lead us off this morning, none other than Miss Wendy Darwell, the Wendy Darwell. She is the expert on all health policy and health regulation, healthcare legislation. Any questions or anything you might not understand about healthcare policy, she is the person to go to. She is our president and chief executive officer, and I am delighted that she was able to carve some time out of her very busy schedule to kind of give us a lay of the land and an update about what's happening on state and federal level and in the realm of population health. So without further ado, I'll turn it over to you.
Well, thank you and good morning again, everyone. I am the Wendy Darwell because there is actually no one else who has my name. So I am literally the only Wendy Darwell in the United States. It helps to have a rare last name if you want to pull that off. But thank you all for being here. As Janine said, we're trying out this new technology. There's a camera that is supposed to pick up whoever is speaking. So for those of you who are remote, if folks ask questions, you should see that. I have this minor concern. It's going to make you a little seasick. Hopefully that is not an issue, but you can all tell us in the post-meeting review how it worked out. So it's an exciting time. The work the collaborative has done has been so very exciting here on Long Island. We're lucky to have such a terrific array of partners. But my work is primarily focused on advocacy. So Janine just asked me to talk a little bit about what we have going on in the advocacy world right now, particularly focused on population health issues. So can go ahead and advance that. I thought I'd just start with where we are. You know, we had an election that officially didn't conclude until Tuesday night, I guess, when the Senate runoff race happened in Georgia. But when we talk about all of these policy issues, we have to, you know, at least talk about the players involved. And I'm thinking of this as a tale of two cities because we've got a very different set of circumstances in Albany versus in Washington. In Albany, Governor Hochul, of course, was elected to a full term, despite some real significant changes here on Long Island, and in particular, Democrats held on to veto-proof majorities in the legislature. We are seeing two significant changes at the state level, though, that will have consequence for health policy. Commissioner Bassett has announced that she is leaving at the end of the year. The governor in an interview yesterday said that she does not expect they're going to have a new commissioner in place by January 1. So it's going to be a little bit longer until we know, you know, who's running the Department of Health and putting a team together there. You know, one of the consequences of having a governor take over midterm and in the middle of a pandemic, no less, is that Department of Health has a lot of slots to fill. And it's, I think, frankly, a little harder to get people to switch jobs and come work someplace in a politically appointed position when you know, the governor had a relatively short term in front of her. So now she's got four full years. I think we'll see a little bit more of the imprint that she wants to put on healthcare. And then Rob Mujica, who is the longtime director of the Division of the Budget, that's the state agency that holds the purse strings. He announced that he is leaving to take a similar role in Puerto Rico, which is a real frying pan of the fire situation. I think that's a place that's very, very troubled financially. But Rob has been with the Division of Budget in the Hochul administration, in the Cuomo administration, and was really the budget policy guru for the state Senate Republicans when they were in the majority before that. So there's a ton of institutional memory that's leaving with Rob. And I think, you know, as they make changes in the Division of Budget, we'll see those flow into health policy as well. Over on the congressional side, we're very fortunate to have Senator Schumer continue as majority leader now with a little bit more breathing room, but not much. With his majority in the Senate, he has been a great champion of New York healthcare, and we're just very, very fortunate to have him in that leadership position. It appears that Kevin McCarthy from California will become the Speaker of the House. He's got a little bit of a revolt going on within his caucus. So that still remains to be seen. To become Speaker of the House, there actually has to be a vote on the floor of the House. That'll take place on January 3rd. He's got a 5-seat majority, which is proportionally even slimmer than Senator Schumer's 1-vote edge in the Senate. So he can't afford to lose any votes because when that actually comes to a floor vote, Democrats in Congress are not going to vote for him. So it's a little bit politically dicey there, although I imagine he's going to prevail. Important to note that Long Island was very instrumental in flipping the House over to Republicans. 3 Democratic seats flipped to Republicans, another one in the Hudson Valley, and essentially you've got the margin there for House Republicans. I think that's good for us in terms of how important it's going to be for Republicans to keep those seats and therefore to you know, be helpful to these freshman members. And hopefully we're going to be able to call upon them for some of our priorities. But that said, it's very hard to accomplish much of anything. You've seen for the last 2 years, a Democratic White House, House and Senate, and still total gridlock. You're now going to have, you know, one of those entities in control of the other party. So it's probably means we're not going to see a lot of big legislation out of Washington, maybe see more happen on the executive side from the Biden administration. Whereas in Albany, you've got these huge majorities in the legislature, a governor of the same party. They politically at least are positioned to take on big initiatives. Financially, in both Albany and Washington, I think that becomes the main stumbling block. The state is anticipating significant deficits going forward, although they'll be okay for this year. And Republicans have been very clear in their campaigns that they want to tackle things like entitlement reform and deficit reduction, and that very often translates into less funding for healthcare initiatives. So I think we're going to see two very different worlds over the course of the next year. So Governor Hochul has had 15 months or so in office. She's been through one state budget, one state legislative session. As I said, didn't really have a full team together in the health department, and has been managing through not just one pandemic, but multiple health crises. COVID is continuing. We've been through monkeypox. We've got a polio outbreak in my other region up in the Hudson Valley, and some evidence through wastewater sampling that has been present in Nassau County as well. Certainly can't avoid hearing about the spike in RSV cases and now flu. So it's tough to put new initiatives out there when you're putting out fires every single day. And that really is what's driven the health policy agenda. But we have seen some evidence of her particular interests. She did stick to the vaccine mandate for healthcare workers. As the COVID numbers got better, you saw the state phasing out their health precautions. I think from my role as my lobbyist part of my job, I think it's fair to say that there has been a little bit more relaxed of an approach to working with healthcare providers on how to manage things like hospital capacity, less rigid than we saw in the prior administration, I think is the most politic way I can say that. But definitely there are some public health initiatives that the governor is interested in. Maternal health is one of them. They put $20 million out there to focus on maternal health. The state has opted for extending Medicaid coverage for 1 year postnatal, which is a really good bridge to make sure that we're keeping folks covered, not just the kids, but the parents. And they're doing a lot of clinical work on the causes of maternal mortality, which are unacceptably high, and a really, really difficult health equity issue that the state needs to address. We also saw her, I think the week before Thanksgiving, issue an executive order calling for the Department of Health and the Office of the Aging to come up with a master plan for aging in New York State. Our state is aging disproportionately faster than other parts of the country. New York is the only state to be designated as an age-friendly state by the AARP. And so we're going to see a lot of collaborative effort between agencies and hopefully stakeholders on that issue. And routine immunizations has really spiked as an issue. I do a weekly call with DOH leadership. We talk about COVID vaccination rates every week, but increasingly are talking about flu vaccination. Janine and Brooke have put together with our partners a great flu vaccine awareness campaign. We've also seen an incredible drop off in routine childhood immunizations. My concern is that the way that the COVID vaccine has been politicized is really poisoned the well for vaccines overall. And we're seeing, your measles, mumps, rubella, all of those vaccines at much lower rates than we had before COVID. There was some dip in 2020 when people weren't going to the doctor, but that's not an issue anymore. And then, of course, their main focus, certainly going forward, but has taken up a lot of DOH time this year, has been ushering through the Medicaid waiver submission. It was started in the prior administration and has now been submitted to CMS for approval. I know you, at the last quarterly meeting you had, my colleague up at Haney's, Kevin Krowicki, did a deeper dive on what's in the state's Medicaid waiver submission. So I'm not going to spend time on that, but I do think it's important just thinking about the policy context here on how the state's priorities have changed. The last Medicaid waiver was $8 billion. It focused much more on transforming the healthcare system with health equity issues as sort of a sideline, and saw many of the initiatives that you've worked on here be a part of it, but not really the main focus. Things like cultural competency and language access, insurance enrollment and charity care. Those were pieces of it, but were really not the centerpiece of that 5-year initiative. The new waiver is entirely focused on health equity. And I think, at least the way it's designed, if CMS accepts it, is going to be much more direct in supporting the social determinants of health initiatives that you've worked on in this group and that we all know are critical to turning the tide here. You know, from my perspective, I don't think that there really were appropriate incentives in the last DSRIP waiver and the last Medicaid waiver to engage payers, providers, CBOs, or to support CBOs in really carrying out social determinant initiatives. That's changed here. One thing that is a very significant change is instead of having funding just pass through the Medicaid managed care plans and hope that that funding actually makes it out into the field in the form of those interventions. That's been scratched. I think that's an important lesson that was learned from the prior initiative. And now there's going to be a fee schedule. So you're going to be able to, know in advance what the reimbursement will be for not just referrals, but actually carrying out interventions in nutrition, housing, care management, connections to care. Also focused on making direct state investments in housing. If people don't have safe housing, I think that's really the starting point for health conditions to go wrong. That is something that, to be fair, the state tried to do in the last waiver. The Obama administration wouldn't go for it. It seems like the Biden administration is more amenable to that being an investment that's considered part of the Medicaid program and the healthcare realm. Investment in safety net institutions. We have a lot of institutions, not just hospitals, but clinics and others that were struggling before the pandemic. It's gotten worse. So we need to really think about how we support those institutions going forward, where they've got a payer mix that's just not sustainable. And a continued investment in workforce, which I'll talk a little bit more about throughout, because that's our most critical issue right now. And then there's a real emphasis here on regional planning. There are a couple of different initiatives that are proposed. I don't know what ultimately makes it out of the negotiations with CMS. They are now in this negotiation period. The state had hoped that they'd get an answer from CMS by January 1st. I think that's incredibly optimistic. Most importantly, we're hoping that they'll have everything negotiated by March 31st, which is the end of the fiscal year, so that the funding that will flow from this will be part of the next state budget. It's really likely to be the only source of new funding for healthcare in this next budget. So it's important to all of us that work in this sector. And overall, they're asking for more than 50% increase in what they got in the last waiver. So we're talking about very big investments here over the course of the next 5 years if the waiver is successful. On the federal side, to the extent that there have been investments in this area, it's been much more in response to COVID. So the American Rescue Plan, which was the first big legislation passed at the start of the Biden administration, was a COVID package. But unlike the prior aid packages that had focused on providing support directly to providers, this one had a lot more to invest in building the community structures around public health. So there was funding to support the vaccine program for, I think, 13 or 14,000 community health workers. They established a partnership between the CDC and the AmeriCorps program to, excuse me, train more individuals to be boots on the ground, providing public health support. Big emphasis on the workforce side. We don't just have a workforce shortage today. We're going to have one for years. We have a retirement cliff we're hitting. We knew this was coming, and COVID's been sort of the tipping point. Primary care docs and dentists being the front line of providing access in underserved communities really got the attention of Congress. And so there's a lot more support to increase those ranks. Of course, it takes a long time to make a doc, right? You've got a lot of years in medical school. So there are scholarships and loan forgiveness programs, but also support for other healthcare team members. Behavioral health specialists is one area where, as you were kind enough to point out, long overdue attention to the gaps in behavioral health access. We are experiencing that acutely in this community, but all over the country. You know, when you look at the healthcare workforce shortage, it's not just a New York problem, it's an everywhere problem. And, you know, all healthcare providers are kind of robbing Peter to pay Paul right now. We've got a finite group of health professionals out there. So more support to bolster the core of clinicians and the clinical helpers. I think very importantly, support for state and local health departments. You know, when I think back to when the COVID vaccine first rolled out, it was extraordinary how much, excuse me, engagement and volunteerism, frankly, it required from the entire healthcare community to be able to pull off a vaccine program. If you look at our peer nations economically around the world, they have huge public health infrastructures. They did not rely on hospitals and clinics and all kinds of community workers to do COVID testing and COVID vaccination. But our health departments are so underfunded and understaffed that really was necessary here. And we got the 988 hotline for suicide and crisis intervention. Last thing I'll just mention on the federal health side, in the Medicare payment rule this year, the Biden administration solicited comments on how the federal government could better measure health equity progress. So when they do that in a payment rule, that's a sign that they intend down the line to make that a metric that Medicare reimbursement is based upon. So I know you've talked about the use of Z codes here. When you're coding patient claims, that's absolutely in the mix, but I think they're looking more broadly at how they can ensure that federal healthcare dollars are being used to support progress on health equity. My concern, going back to that first slide, is that we've got this change in the political dynamics. Are we going to be able to sustain that funding? And what's going to happen to, say, those 14,000 community health workers? Are we going to have a place for them and an appropriate role? Is there going to be funding to continue to support that? Go to the next one. I wouldn't be doing my job if I didn't mention that we've got a health system that is very much under stress right now. I wouldn't presume to speak for the other healthcare provider types, but I'll speak for hospitals because this is what I spend the vast majority of my time doing. Is how we come out of COVID. You know, we've been in a place for most of this year where COVID is sort of settled at kind of a low level. About 10% of your hospital beds are still taken up by COVID patients. That's not going away. We're seeing those numbers actually climb now. And on top of that, we're dealing with the flu and the RSV cases. We don't really have data on flu and RSV the same way that we do for COVID. And so It's been a little bit difficult to track exactly where we are on that. But beds are full right now. And when you've got a significant workforce shortage, as I know every healthcare provider does right now, that becomes very difficult to manage because, of course, your workforce lives and works in the community and they get sick too. I had one hospital tell me they had 40 people out with COVID earlier this week. It is hard to manage a rising number of cases when your own workforce is getting sick. There are significant financial shortfalls coming out of hospitals. Coming out of COVID, hospitals, 80% of them in the state either have negative operating margins or unsustainable margins, just barely over break even. We just completed a survey and we'll be releasing it soon. Hospitals across the state, pharmaceutical costs are up about 40%. Labor costs are through the roof because we're using expensive contract staff. Energy costs, all of the supplies, you all are experiencing this too. We experience it here as well. So it's hard to pull out of COVID and see your way to the next innovation or transformation of healthcare when we're still kind of stuck in this one, but we're quite determined to do that, and we need all of these partners to be able to be successful. So I wanted to just end by getting some feedback from all of you. I do think that there is a lot of overlap between what I'm working on in support of hospitals and what you all are doing in your work. I think of coming out of COVID with a focus on health equity this way. We all knew that these gaps were there in our communities. I think the public has a much better understanding of those gaps. COVID just laid bare for everyone to see that there are real consequences to inequity in healthcare. It's not just access to healthcare, whether it's insurance coverage or a lack of providers in your neighborhoods. It was access to childcare, people not having paid sick leave and so going to work anyway. The fragility of our supply chain really hampered the ability to respond to COVID. We've fixed some of those gaps, but certainly not all of them. I think the biggest gap that was exposed that didn't get attention before, as I said earlier, was just how fragile our public health infrastructure is. My personal beef is that we need to have data collection systems that are much better than what we've had now. I think of the state's data systems as a hamster running on a wheel powering some sort of computer system because it's that ancient. Every time they wanted to make a change to the daily data they collect from hospitals, it would take them 2 weeks to reprogram it. And I'm just talking about changing the wording of a question. That meant it took a while to get started. We didn't know where all the COVID cases were. We didn't know how bad the capacity issues were. The state's getting this money from the federal government, and my personal hope is that they're really going to invest it in improving that infrastructure and improving transparency. It'll make the work of groups like this much easier to do if we have access to data that is current, that's collected in a much easier way than it is now. So that's on my list of priorities. Hearing all that, I'm interested in your feedback on where you think we should be focusing as we're coming out of COVID, knowing that the funding situation is going to change to some extent, but that we've got a state that is really focused on equity. Where do we want to see those investments made? And I'll stop there and
well, Wendy, maybe I'll comment on it. To begin with, from the home health perspective, we were very happy with what the state did, giving out the
minimum wage increase.
For the professionals, giving that $1,500 for that, and that was good. That was great. Then what happens is a couple of months later, the state mandates this $2 increase that we had to pay our people. Okay. We have no problem paying our people, provided we get the money. The state hasn't moved to changing rates. and they're locked in with the MLTCs, okay, which control the money. So the state gives the MLTCs money, the MLTCs don't give it to the providers. Okay, I have multitude clients throughout the state that are very concerned about staying alive, but yet they render good care.
Yeah, that's absolutely a fair point, and on my advocacy list for this year is getting at that issue, because it's not just home care. If you go back to the prior district waiver, this was an issue, funding passing through the plans to the providers and the CBOs. But it happens a lot in state policy. We have Medicaid rates in the state of New York that on Long Island only cover 60% of the cost of providing care. It is an enormous struggle to increase those rates. Often we go to the state with this data and these arguments, and they say, well, we can't increase Medicaid rates, but we're going to increase rates to the managed care plans, and you're going to get it there. And from my perspective, that's a completely unreasonable alternative, because as you said, the funds don't always make their way down. And even if they did, if you're a provider that's in 3 or 5 year contracts with managed care plans, you're not going to see that funding for years, and we've got a crisis today. So for lack of a better term, the enforcement of those investments is something that's absolutely on my list. And I'll tell you, here at the Hospital Council, we only represent hospitals, but I have to care about what happens in the home care world and in the nursing home world, because they become hospital problems. And we've seen this already. My colleagues up in Western and Central New York, where they had a terrible workforce shortage prior to the pandemic. I think the nurse vacancy rate in Central New York was about 20% before COVID. They lost a lot of people due to the vaccine mandate. That did not turn out to be nearly as big of an issue on Long Island as it did in other parts of the state. And right now, hospitals, the 2 largest hospitals in Rochester have 1,200 patients sitting in hospital beds who have been ready to be discharged, but there are no appropriate settings for them. There are not enough beds open in nursing homes due to staffing, and there's not enough home care availability due to staffing. So that's a hospital problem, that's an everybody problem. And it's first and foremost, a patient problem, because the hospital is never the best place for anybody to be, especially when they could be more comfortable in their home.
Yep.
I think there should be a greater focus on staffing agencies. I think right now they have too much leverage over the healthcare providers. I don't believe they should be able to contract with any more than maybe a few organizations. There's no reason why, and I'm very fortunate we're not using contracted labor, but I can tell you, I was a long-term administrator for 8 years now. And up until the last 6 months, I've used contracted labor. I work in Pennsylvania. So the labor shortage, while everybody thinks it has a lot to do with COVID, it doesn't. It's been going on for a very, very long time. And there have been a lot of reasons that I won't get into where people have been pushed out of the industry. There's no reason why, as an administrator, you should be competing with 5 other long-term care organizations of increasing the rates for your staffing agency. And if you don't bump up what you're paying individuals, they will call off and go with another organization. So next thing you know, you're in a bidding war every Friday to cover the weekend. That's unacceptable. And I think there should be greater rules around how many organizations each staffing agency should be able to partner with at one time.
I can tell you that we have gone after this issue aggressively at both the federal and state levels. We tried to get Congress engaged. We've asked the Federal Trade Commission to investigate what are really anti-competitive practices by the staffing agencies. And we've asked the Attorney General in New York State to focus on it as well, because we have seen, I mean, it's highway robbery. When you look at some of the rates that they're charging And it's not all getting to the workers.
Exactly.
In a crisis, we want all hands on deck. We want for healthcare workers to be paid well. But 2/3 of that money, probably, we don't know because it's not transparent, but it seems like about 2/3 of that money you're paying is going to the agency. Agency is laughing all the way to the bank, the worker's not getting it, and you're breaking the healthcare infrastructure with those costs.
We've actually been, in my history of doing this, when I do contract with the staffing agency, I will tell the employee how much I pay the agency. And oftentimes they don't know. And when I tell them, hey, just so you know, I pay $60 an hour for a certification that takes you 4 months to get, they're appalled. And then next thing you know, they reconsider their options. But that's another thing. There should be a greater level of transparency with these contracts. That's an area. Another area I think of opportunity would be transportation. A lot of our workforce for a long time, they would utilize Uber or Lyft to get to, from one place to another. And right now, the charges for Uber and Lyft are even more expensive, sometimes than owning a car. So that would be a great opportunity, I think, to look for some kind of program that would assist healthcare workers with affording the costs associated with transportation.
Yeah, that's interesting because we have a grant with Uber and Lyft. And it started out as a vaccine to be able to get people to get to the vaccine site and get vaccinated. And then it turned into, just getting them to healthcare appointments and things like that. But I wonder if there's wording in something like that that can be used for healthcare workers.
Yeah.
And that grant is time limited too.
Well, it's interesting, we just got a new one, our original one was like 50,000 and they just gave us like 500,000. LIHC, Long Island Community. No, it's not Long Island, it's LIHC, I think, I'll look it up and I'll send it to you. But it's now for patients, but it's very interesting, I'll look it up right now, that maybe there's things in it that it could be used for that as well. I'll get you the information.
Did you say it went up to 500,000?
We got a lot. I mean, we won't see all of it because there's administrative costs. Most of that money does go towards Uber and there's a special account that you just set up and we're able to contract rides for patients and stuff, but we got a lot more this year. When it was in the middle of COVID, I believe we got 50,000 and then they opened it up to a lot. So there may be leeway if I'm gonna find it. I'm gonna find it right now.
To know who that
Can I
grant
ask,
is.
you're getting the grant or Uber is?
We got the grant to use for our patients. They set up a special Uber account that you just schedule it, so everything goes straight through there and we don't have to pay out for the rides, but our patients are able to get to their appointments and things like that. But it started out just as a specific vaccine.
But now it's for appointments of all.
I think we could use it for all of it, but I'm gonna look it up right now.
So let me know what that is. I'll be interested.
Right, and then if you can share with all of us, that would be
Share,
great,
sure.
yeah. So as a Nassau Community College, I wanna, give my 20 cents in that. Workforce development, we are actually focusing on not only community health worker program, also community mental health worker program. Mental health is #1 issue now, and it will become even worse next year. And we are talking with Northwell on that, how we will train these students. And what we do under workforce development, not only that we have certification program, we have micro credentials. So our community health worker program that I will ask Dr. Xavier to explain in detail, he's the grant director for the program. We have non-credit training, we have some credit courses, and then we have certifications. Everything embedded in one program within 4 months. It's an accelerated program. They have internship and we have graduated almost 100 students. Community health workers, we have 87.9% full-time employment rate, 99% completion rate, and it's very successful. So what we do, we took the same model and created a community mental health worker program that we will start running next year. And now we are actually focusing on specialties, as you said, which was very true. What's going to happen to these 15,000 community health workers? What we can do, we can actually do in between short training for different specialties, because they have the basic knowledge of the outreach, patient navigation, computer systems, and all that 9 yards. But if they want to go into oncology, they can have the specialty and go to oncology if they want to go to certain thing. So we are also working on that. I know that we were in a meeting with Kathy Hochul, and we were talking about economic development, mostly focused on trade programs. Yes, we are also creating trade programs and everything, but I think we really need to focus, as you said, maternal care and mental health and community health, because this generation, if you see, not only people who are aging are depressed and committing suicide, young children, school-going children, they have no hope. So we really need to get together and work on that. Do you want to explain about community mental health specialty?
Yes, as you're well aware, mental health is at the seat of a lot of issues that we're going through. And the mental health is not only just mental health as we hear it by definition, but also harm reduction, suicide prevention, substance use disorders, and so forth. Family development and family social economic planning. These are all things that are part of the mental health structure, because when these things fail, we end up with a mental health situation. So really what has happened is the paradigm has shifted. Before it was just mental health as a situation we're dealing with, whereas now mental health becomes the disposition of many other issues that we're faced with, which brings us back to the core curriculum that we have, that we so well value at the Nassau Community College, which is the Community Health Worker Program. So we're really looking at this differently. We're redefining and sort of refining as well the lines of what is expected of Community Health Worker Program, of workers itself. So we have specialty programs that are in different areas, which not only increases the awareness and preparation for the worker, but also the businesses. So what Nassau Community College has done is we have developed this surveying system, which we do between 3 and 6 months, where we're constantly evaluating what you, the heads, are actually in need of. Okay, so we're in constant communication with organizations such as yourself. We're not just about training the workers, but also about training the staff and being the best asset of support that we can to your organization. So today, as we mentioned, we extend ourselves as a platform to you. Communicate with us, communicate with, let us know what your deficiencies are, okay? Because we're taking over the reins of leadership here on Long Island to make sure that you get what you need, and the workers of tomorrow are going to be the saviors of families of all time. It's about bringing the families together, bringing the communities together, and bringing, of course, you, the corporation. You're not just going to accept what you see on Indeed. We're saying, let's redefine that. Let's train the individuals that you need. And then we can have our own network where you can say, hey, I need someone in maternal health. We can tell you, we have a database of individuals that we train that are ready for you. So workforce to us means more than just training someone to go in. It's actually consulting with you to prepare them to meet your needs.
And you have a cohort of students ready to start in January, right, for the community health
Yes,
worker
correct.
program?
We place with LIHC, we place with Northwell,
Right.
we have many hospital, nonprofit
Right,
organizations.
and in fact, last year, the collaborative did have, we offered an externship, I think you called it, to one of their community health workers, and she did a fantastic job. I mean, we're a little bit of a different structure. We're not immediate patient to community care, but we are a step removed from that. So in an indirect way, we're still providing care to some extent. And then that was a really great experience, and so you really should avail yourselves of that if you're interested.
I'll ditto that. We've also used to.
Yeah, they are big supporters.
Yeah.
They also
And
provide.
one in the epilepsy services piece of our organization, one in the mental health piece of our organization. They've been wonderful.
And I also neglected to point out that we tend to think of the healthcare workforce shortage in terms of doctors and nurses, and certainly the numbers are very large there. But if you don't have 2 or 3 lab techs at a time, you don't have a lab running in a hospital, you don't have a functional emergency department. And so for jobs like lab techs, radiology techs, medical assistants, shorter term educational programs where the community colleges in particular play a critical role, we really need to bolster the workforce across the spectrum, and the work you do is really, really important.
Yeah, we did a survey with high school seniors, and most of them, interestingly, want to join a health field. And they were asking what programs we are running. So not only that we want to provide them training, but we want to let them know, don't go anywhere else. Go straight to work and continue your education. That's the right way to give them a pathway.
Yeah.
So that's what we are working on. So, but of course, we need support from everyone.
Right.
So we are one community college.
What is the cost to the student?
So far, I ran community health worker program for 5 years, thanks to Department of Labor, Bank of America, multiple funding, so it was no cost to them.
Wow.
They paid for the full
Great.
program, credit
Awesome.
courses, books, even their travel to internship sites. And it was
So
wonderful.
There's an opportunity there for hospitals and health networks to also.
That's exactly what.
Yes.
Yes.
And there are more and more of these, what I call learn while you earn programs being
Yes.
developed, right? So that you can be working at perhaps a lower level job than the one you're training
just
for,
like-
but earning a paycheck to support you, and programs that are designed around the classroom time that you need so you can be manageable, right?
Because they
Getting a
are
paycheck.
confused.
Yeah, they are,
You should
right. They
see
need
the
direction.
anxiety level I notice in high school students and even community members when they come to
Yeah.
us and I interview them. We select them, we have different surveys and different ways that we do assessment and selection just to make sure that once they complete the program, this money doesn't go on waste and they work.
Right.
So that's why we have such a high rate. Yes.
Yeah, I want to just comment because I work for a mental health agency, which we also do, we believe very strongly in hiring and encouraging a workforce of people who have lived experience with mental illness or mental health. We actually have a training program that trains people to become certified peer specialists. So I'm just curious about the intersection between community mental health workers and that, and willing, really eager to have a conversation about that. The other piece is there a Suffolk County counterpart to Nassau County? I mean, Suffolk Community College doing anything like this?
So yes, we have satellite campus. We are partnering with Farmingdale State University. They're partnering with EOC, so they will provide us all the campuses access for this program, so we can run community health worker and community mental health worker both. So
Okay.
that wouldn't be a problem.
Yeah, I'm a huge, the Office of Mental Health is actually talking about the health equity disparities even in the mental health workforce. That we need to, what's the barrier is usually 9 years of education that prevent people from, impacted communities from being able to advance and move up and get jobs. So starting from a community health worker perspective, and it's taking people and training them in the roles of what they're going to be doing. That doesn't require a license, et cetera. But I'm just, I'm a huge proponent of that. We just had a Project Hope, FEMA Project Hope, which is ending December 12th, but what the learning from that in the community and being embedded in the communities and working with the people has been foundational. So really like to talk to you. I'd like to find about the Suffolk County connection.
Absolutely.
But what, for a community mental health worker, what are they trained to then go in and do? That's what I'm curious about. What's your curriculum? What's it focused on?
So I can send you our program design and
Yeah.
the curriculum outline. We have actually did the survey with multiple hospitals and everyone who are actually working in mental health topics they want us to cover. So we have all those topic covers under community mental health fundamentals. And then we actually partner with NAMI, National Alliance for Mental Health. We asked them to create a certification for so they created a certification for 45 hours. Then we have 2 courses from current side, which cover other topics. And then we have different certification like mental health first aid, they have Narcan, of course, epilepsy, Alzheimer. So they will be packed with all this knowledge, like interviewing skills, good listening, cultural competency, and like conflict resolutions and different topics. I can't just skip all the topics. It's like maybe 40, 50 topics that we will be covering. And once they complete that, they'll have 75-hour internship. And then they will start working. They can work as a, how I describe, they're not really therapists, but they can work someone in between therapist and patient. They're not counselor, they're
almost
not
like-
in counseling,
almost
but
like peer.
right, so they,
Exactly the model.
yeah. So peer support, community education on mental health and all that, they, just like community health worker, they will be wearing multiple hats and they can fit in to nonprofit organization, they can fit into hospital, clinics, any place easily. Meaning for community engagement and education and clinical setting, and it will also.
Yeah, I really like to try
And go in more depth, and anyone else who's
Yeah.
interested, reach out to
And
us.
you do mental health first aid training?
Yes.
Yeah, we're also on mental health
So-
first aid.
We'll have all these, everyone's contact information will be available to you. Anyone on the call, would like to talk about with, issues in advocacy, issues they'd like to see addressed, moving forward?
This is Lori Andrade from the Health and Welfare Council of Long Island, just kind of piggybacking on the community health worker discussion that we've been having. The Health Equity Alliance of Long Island has been, really preparing for the social determinant of health network within the waiver by really looking at 2 pieces, the touch and the tech. The tech being the referral technology to ensure that that clients are they're properly intaked through a screening tool, and brought into what we're utilizing as Unite Us for referral technology, and then ensuring that there's closed loop referrals so that individuals are receiving all of the social determinant of health network services that they need and that they're eligible for. And then the other side is the touch, which is really the community health worker, and working with our colleagues in Nassau County, as well as we did an assessment of the community health worker landscape, working with Public Health Solutions, which is really a expert in CHWs in the city, where there's a really built out workforce already, and looking at what does the landscape look on Long Island, and looking at what are those core functions, because the other piece of this, of course, is the sustainability of these positions. How do we ensure that they're reimbursable by Medicaid so that we can continue to have community health workers in our communities and being paid, a competitive wage in our communities. So we've been looking at what are those core functions that we want to make sure are reimbursable, looking at the opportunity of the waiver as a way to do that. So we're just about completed with our assessment report. We've developed a subcommittee, a CHW subcommittee, to look at what are some of the policy issues that need to be brought to the state to ensure that there is, that these positions the core functions are reimbursable, and that we can sustain them moving forward. So we welcome anybody's participation on the CHW subcommittee that we have as part of Healy, really looking at sustainability of CHWs and reimbursability and the integration with the technology that we know is a big piece of the waiver.
Thank you, and they are biggest supporter of this program. Thank you so much for all your support.
Anyone else have any questions for Wendy? Any other tidbits of information you'd like to?
I just want to say that I emailed Brooke the story, the two players, Lisk, and so it'll be the original release of the original grant.
Okay.
But maybe you could do some research there and see if there's still opportunities
All right, we'll
to
send
send
all that
So I
information
sent that,
out
just
as our,
the link to you.
as
Thank you.
our meeting summary. We always do a meeting summary, so we'll include all of that information. Anyone else have any questions for Wendy?
I know you've got a lot of other
Yeah.
stuff to get to on your
But
agenda.
I'd just like to thank Wendy, give her a round of applause. Fantastic presentation.
Thank you.
She's always available, I'm always available. If you can't reach her, reach me. If I can't answer a legislative or regulatory question, I know where to go to get the right answer, and I can get it to you, but do appreciate.
My pleasure.
Thank you so much.
Give up a chair.
Yeah, so there's another seat up here. If somebody wants to move to the table, you're welcome to do that. Okay, so let's move along here. As Wendy had mentioned, well, obviously, well, we all know we're in the throes of a bit of a surge with COVID, certainly a surge with the flu. And we developed the Suburban Hospital Alliance and Nassau Suffolk Hospital Council. We developed 2 campaigns, social media-based campaigns that you can avail yourselves of the materials that we have on our website. And if you want, we can co-brand and throw your logos in with whatever you want to do. So I thought we would just play the first one, which is the flu vaccination campaign, which we are holding in conjunction with the New York State Association of County Health Officials. So our local county health departments, we have one here, are also pushing to get your flu vaccination. And I understand, I just heard on my way in this morning that flu vaccination uptake has been not very good. Not many people are availing themselves of getting that flu shot, and they do say that it does align pretty well with this year's flu strain. So if you are inclined to not want to get the flu and don't mind getting a flu shot and you haven't gotten it yet, I highly recommend that you go and do that. So this is just a campaign we threw together. Where was the bug? We like the one where we were swatting the bug, the flu bug. That one, right? So it's just this is a host of different posts. So that's available to you right from our website. Let us know. We'll pop in your logo if you want to co-brand. And then we did another campaign focused on COVID vaccination for children because they are lagging desperately behind the rest of the population. And of course, where are children right now? They're in school, they're in daycare settings, they're in congregate settings, right? The winter months are here. They sneeze and cough and they don't really cover their coughs or, so the chances of them spreading it are much higher, are much more likely than other populations. And they're one of the least populated groups. I think with the less than 5-year-olds, it's like, what is it, 3% or something? It's very low. And it gets a little better as you move along. Is there sound on this? Or?
The sound's not coming through, but I knew the stat was in the video. That's why I wanted to play it.
Okay, well, there's
34%
some
of
sound
kids.
to this, and this is geared toward parents and guardians. You can read it for yourself. Again, we can co-brand this if you'd like. And we have it all over social media. And hopefully these messages, social media is only good as the followers you have, and then is only good as those who see it then share it. So it's not the be all and end all. But when you don't have much money and you're on a shoestring budget, this is kind of the way you go. And then of course we do work to get earned media as well, which we did get some inquiries, mostly from reporters who were alarmed and wanting to know were the hospital beds, were there any hospital beds left? But they were kind of jumping to conclusions. I can assure you there is capacity, so don't worry about that.
Could that be considered a PSA?
Yeah,
So
it could
we
be. It could be. Yeah, you could run it as a PSA. If you could get somebody to run it, that's the whole thing. All right, so there's that. next on the agenda, I just wanted to check in on the hospitals who are here and our health department representative who is here regarding their community health needs assessments. Maybe I'll give a really quick summary background of the beginnings of the Health Collaborative and how we've come to be where we are today. It really stems from the state's strong encouragement. It was never a statute or a mandate, but the state's very strong. I feel like I have to keep turning around because people back there. Very strong. I don't want you to think I'm ignoring you. Very strong encouragement that hospitals and the local county health departments work together to conduct a joint community health needs assessment, right? So they've always done community health needs assessments on their own. But since the state unveiled a prevention agenda back in 2013, and that's its blueprint to ensure that they want New York State to become the healthiest state in the nation. They have a whole bunch of metrics. They have 5 priority areas to choose from, one being chronic disease reduction, another working in the area of substance abuse and mental health issues, and vaccine prevention, and a few other ones, women and children's health, and another one I can't think of, but there's 5 of them. So they wanted these hospitals and the county health departments to work collaboratively on a community health needs assessment by region, and Long Island is a region, right? So we have a Nassau Health Department and the Suffolk Health Department. We have hospitals in Nassau County, have hospitals in Suffolk County. We have systems that overlap, right? Have hospitals in both counties. So they turned to us as a natural coordinating entity for this collaborative work because we represent all the hospitals. And so that I was asked to do that back in 2013 expressly to do a joint community health needs assessment. So we gathered around with some community-based organization input as well, right? Because you cannot do a community health needs assessment unless you know what the community needs, and the community based organizations are right there. They're the boots on the ground. They really have their finger on the pulse of what's going on. So we brought everyone together. We designed a community health needs assessment called the CHAS, Community Health Assessment Survey. We had epidemiologists, we had other public health experts, we had medical doctors, making sure that our questions were appropriate. We did kind of fashion it off of some other evidence-based questionnaire way back when, you're telling me go back 10 years now, so I'm forgetting a little bit. So we put together this questionnaire. We sent it around in a very crude way, in SurveyMonkey. I got the responses back. I did the analysis. We didn't really get that many responses, but we got enough. We had our joint community health needs assessment. So I thought that would be the end of it. And maybe we do it every 3 years, right? Because every 3 years you have to do this comprehensive community health needs assessment. Well, there was such synergy and such energy and value that everyone, all these disparate organizations saw in working together to attack a problem, right? From all different perspectives, right? So that's that collective impact model. And they said, well, we should keep meeting. We did this, so let's keep meeting. I said, all right, so we'll keep meeting. So we kept meeting month after month till I finally said, I think maybe we should give ourselves like an initiative, a name. And that's when we said, we'll be the Long Island Health Collaborative. So that's how it came to be. And so to this day, we've gone through, I think this is the 4th iteration of a 3-cycle community health needs assessment. And along the way, we got funding from the state through that population health improvement program. We were able to become much more sophisticated in our data collection and analysis capabilities. And we continue to do that to this day, even though that funding ended in 2020, but we are still able to, through the support of the council, the financial support of the hospital council, to continue to do the analyses of those questions on the community health assessment survey, which really look at community an individual perception of health needs, health barriers, looks at all kinds of social determinant of health needs. What are the pressing health concerns? I can tell you cancer is always rising to the top, even though the #1 cause of death is heart disease. So that's up there too, but cancer always rises to the top. We have seen over the course of time, because now we've been able to do trending, concerns related to housing and certainly transportation. It's a big one, transportation. Access to care and also the ability to afford co-pays, deductibles, and even insurance if you are insured. Because we do have a high insurance coverage rate on Long Island, but people are still even having trouble meeting those costs, right? Certainly if you have a high deductible plan, you're gonna lay out $5,000 before anything's covered. It's kind of a shock if you happen to fall off your roof and break your arm, all of a sudden you got this huge bill that you didn't think you were gonna have. So it's evolved over time to become this kind of population health management entity for the region. We follow the collective impact model. We sort of, I guess, serve as a backbone organization because we're still collecting that data. We're still analyzing it. We do have a partner up in upstate that takes all that data and runs it through their analyses, and it's much more sophisticated than that first time that I did it on my own. I'm a words person, not a numbers person, but I soon became one quickly. So we were able to continue it. And so even when we lost that funding in 2020, and everybody lost funding in 2020, right? Because the state kind of froze everything. And I knew we built a really fantastic infrastructure because we have colleges, also the colleges and universities are involved. Like I said, the hospitals, all these CBOs, diverse CBOs. And I said, and knowing the way we were headed and even before COVID, I could see the way we were headed. We were beginning to understand the impact that those social determinant of health factors had on health. I always would laugh when during the pandemic and as we were going through it, they would say, oh, the pandemic has really illuminated those social determinant of health needs. And I thought to myself, well, we were already talking about this, years ago. We knew that there were concerns. We knew that if you didn't have proper housing and if you didn't have proper food, particularly if you had a nutrition related diagnoses like diabetes or even hypertension, any of those chronic diseases, you were not going to be able to maintain your health or be as healthy as you could be. We knew all this. So the pandemic really did shine a light on that, and we saw the inequities, and we saw those who were affected by social determinant of health factors. A lot of frontline workers who had to take the subways and the trains, right? Those who were living in intergenerational housing because that's all they could afford, and there was a lot more transmission. Now, like all these things we knew they existed, but the pandemic really highlighted it. So anyway, that's kind of a long-winded summary of the collaborative. So here we are still today, still doing what we're doing. I'm still collecting that zip code level data that no one else is collecting on Long Island.
I have to tell you that data, when I'm writing grants, is so important to be able to go back to your website and find everything and just hone in on the questions and the
Yes.
data that I need that I wouldn't have.
Yes, and when we had funding, we were also able to do customized research reports, right? So I know we've done it for EPIC, done it from some other organizations, but once I lost the funding, I couldn't do anymore. But I always point everyone to the website, then I said, refine what you possibly can. So anyway, so the community health needs assessments do draw upon that CHAS, right? That community health assessment survey that we analyze. So that's kind of a quantitative survey. And then we also, along the way, have done focus groups. We've held community-based organization summits where we've done a qualitative analysis of the recorded information. But this time around, again, because we're on a shoestring budget, like everybody else, we designed a community-based organization survey to go to key leaders, and you might have even gotten one, which was similar to the one we sent to individuals. So kind of asked kind of mirror questions, but it was from the perspective of you as the provider. So we analyzed that. We also then asked those who answered that survey if they would be willing to engage in a more in-depth interview with us so that we could conduct qualitative analysis of what their questions and concerns might be. And so there was another, I think we got finally 22 people said they were interested, and we ended up with 12 who actually did the interview. We recorded it, we ran it through Atlas TI qualitative analysis software. Brooke and I have learned how to use that. And we came up with key themes, and we have a report on that. So that's also part of the data that community health needs assessments, hospitals and counties can use. And finally, we worked with the Stony Brook University over the course of a number of years in a very unique project whereby through random selection, we randomly selected libraries throughout Nassau and Suffolk. And what we wanted to find out is how well equipped well, first of all, what were the patrons asking of their library directors and reference librarians regarding social needs, health literacy? Are they asking for blood pressure screenings? Are they asking for help with completing SNAP applications, whatever it is? So librarians and library personnel, they're not social workers and they're not really trained to do that. Yet a library is a very trusted source in the community, and that's where a lot of individuals are going to turn. And so we decided that we would want to gauge what were the questions, what were the concerns being asked, and how well equipped were those library directors, reference librarians, front desk clerks able to respond and help the individuals and help the patrons. So we did randomly selected libraries. Researchers from Stony Brook University and Adelphi University went in. They had an instrument, a pre-approved instrument, and this was piggybacking on a University of Pennsylvania study that was done in the Philadelphia library system. So it was very well thought out. Everybody got their IRB approvals. We went in, we recorded, we had the recordings transcribed. Stony Brook students and their director went through, they used a qualitative analysis program to pull out the key themes and what was rising to the top. And they did an analysis, which we were part of, and that's available as well as another resource. And what was found is not different, right? Housing needs, need for nutrition, inability to afford co-pays. They wanted in very higher resource libraries, it was more of enrichment programming that was prevalent, like yoga classes and cooking classes. And in a lower resource library, which matched up with the high need zip codes that we all know exist, they needed financial literacy courses. They wanted to find out, they wanted health screenings. They wanted information on where they could apply for SNAP. And oftentimes the library would even collaborate with the Department of Social Services or some other organization that offered SNAP enrollment. A lot of the hospitals would go in and provide blood pressure screening or mental health screening, whatever it might be, right? So there was that actual need uncovered and then the need being addressed. So that was another source of data for the community health needs assessment. So lo and behold, that's kind of, we're now, like I said, I think in the third iteration, right? So this is 2022, 2024 will be the next one when we do this full assessment again. And I just wanted to check in, because hospitals and the counties are required to file these every 3 years, both on a federal and a state level. There's a federal requirement and there's a state requirement. Just wanted to see, since I have a couple of hospital members here, how you're doing, anybody on the phone who's from a hospital. We at the collaborative write a template report for both regions. We put together all this research, as well as some other secondary research. We look at Burfus and the NHANES study, all kinds of CDC places. We pull from a variety of sources, and we put together, I think, a pretty robust way for you to at least start, right? You can use it, not use it, use some of it, not use it at all, and at least get you going. So I just wanted to check, since they're due on the 31st, the state one, how my county person's doing over there.
Well, I'm working on the work plan now, and I've only been with the county since April, so this is the first time I'm ever creating a job for the county.
Yes.
But I'm learning that there's so many partners that we're working with to address like cancer screening and tobacco prevention, working with the opioid epidemic, with Narcan trainings and MAT accessibility. So we are progressing, but from like EMS is like told me things like we'll send somebody to the hospital for the intervention crisis, and then like at 9 o'clock, and then by 2 o'clock they'll overdose again, and so so the problem is like there's accessibility for like Narcan reversal, but then there's no like keeping these people in programs. I think we've met like there's a wait list to get into our clinics and things like that. But overall,
that's the problem, because we don't have mental health
yeah,
infrastructure we really need.
yeah. And so as far as the child ship's going, I think we're really addressing communities of color and also low income.
Right,
yeah.
That's the disparity that's been uncovered, right?
Yeah, because there's large pockets, like there are pockets within some counties. We do provide SNAP benefits to 13,000 residents. So we noticed that there's a great need for, and all the community-based organizations that we work with are doing great, like helping us in such a great way, but we could always use more help.
Always use more help.
Yeah.
So you were kind of thrown into this whole process. And I know you were on the phone with me, and I was trying to help you as best I can.
Right.
But it seems like you've gotten a handle on it, and
right,
so
yeah.
that's good.
Yeah, I think to see more with the Minority Health Division. They are working with different houses of worship, at least 50 communities, at least 50 houses of worship. But like, I'd like to see them build their programs up, because they do so much. They tackle baby bundles for mothers in need, and then
and the research shows that, again, faith-based organizations are trusted sources in the community as well, so people will turn to them. So they are great partners to have in your community. I know, Kaimona, you guys submitted back in, because you're on a different federal fiscal year.
We had to have ours done by March so that our board can approve it by May, and so we are done.
You're
Our
done.
plan is up, done, and we are actually doing the work now.
Okay, and then you'll be doing this again in 2024, right? So, but you'll be starting a little earlier, right?
Start
So-
earlier.
Yeah, so, and then there was another.
Stony Brook.
Stony Brook.
Yes.
Stony Brook.
I'm not sure.
Okay.
I just emailed our planning team just to see, because they usually work on the, obviously the grants, and then we'll discuss it, with us interested, areas. I know that this has been, the previous survey has been hugely important to us in terms of using that data, because we're really working on building our health equity strategy, both internally and externally. And, you know, we have different subcommittees, which Erica is part of as well, for the community outreach. So I will check to see where we are, because I think more recent data will just help us to be able to
Absolutely.
continue to really work on this. But I would say it's one of our, you know, in addition to all the other health system issues that we're talking about, I think the health equity work is really our number one priority right now.
And Daryl, how you doing?
We're-
We've been intimately involved.
You know, I can't say enough about your professionalism and you bringing it all together. So we really appreciate that. We're right on track to have everything approved by the board in a few days.
Few days, yeah.
And thanks to you, we'll be able to, everything is done for the 6 hospitals and we'll be able to submit them.
Yeah. Cheryl came on board kind of in the middle of this, so she kind of got, you know, she was like thrown into the lion's den.
Not really,
No.
you know, in my previous
Yeah.
work, I, you know, dealt with a lot of CSVs and community work plans, but having to be on the system level and have to, you know, help 6 hospitals.
Six at once,
was-
so,
Yeah, and we couldn't have done it without your help.
Yeah,
So
thank you for your good work.
Thank you. Well, okay.
Yeah.
Now I got a great partner sitting over there, Brooke Olivieri, who is phenomenal. We're a good team.
I got a question for you. You were talking about before assembling data, and you guys do a great job on that. And you mentioned modalities, you mentioned cancer. Do you do other modalities in tracking data in Long Island?
When you mean modality?
Other illness, cancer?
Yeah, I mean, there's a whole series of questions with choices. Those are the ones that keep coming to the top. That's why I.
Okay, only reason I bring one up, multiple sclerosis. It's the biggest growth.
Yeah, I think there's like neurodegenerative
Okay.
diseases are
Okay.
one of the choices in there,
Okay.
yeah. And you can see, now again, this is convenience sampling, you have to remember that, this is convenience sampling. So, what do? We push it out as much as we can, we got a Survey Monkey link. And also we have hard paper copies, because a lot of people still want to fill out the hard paper copies. But we depend on each of you, right, with your clients, your patients, whomever it is you serve, to get those surveys filled out. Even when they come back to us paper-based, believe it or not, we manually enter all those. So you don't even have to worry about doing that. You can give us a stack like this. We have a survey entering marathon in the office, and we get them all done. But it is convenience sampling. I would love for it to not be convenience sampling. I would love for it to be the ability to rent a bunch of zip codes, right, and mail the survey out, or do it through digitally and send the survey out with the survey link in a more random way. But that's cost a lot of money. It's just not feasible. I know that there are some communities, particularly with Kaimona, they really want to focus on Hempstead. And I didn't have a lot of responses from Hempstead because I just didn't have a lot of responses from Hempstead for a lot of reasons. Nobody was going knocking on door to door. I don't know if the community-based organizations in that area how aggressively they were asking people to complete a survey. But be that as it may, and maybe in the future, in some way, shape, or form, we can sort of solve that problem. So we get more of a broader representation, both by age, gender, sex, location. But for now, we have what we have. And then you supplement that by looking at other secondary data sources, right? The state has a ton of data, the BRFIS data, the National Nutrition data. There's all, the Youth Behavioral Risk Factor Survey. I mean, there's tons of stuff out there. After you start doing this a while, you kind of know where to look. And that's another thing we try to do here at the collaborative, is provide you with direction if you are working on something. We consider ourselves information processors. We're not data scientists. We're not epidemiologists. but we have a unique combination of both communications, marketing, and public health skills, which I think has served the organization well and anybody who is participating in the organization well. So that's what I just kind of wanted to check in and see how everybody was doing.
Can I mention a quick initiative that we're doing with that, and then we can talk offline about getting some more data sources. So one of the things that we're doing, because we found the protective health factors for behavioral and mental health, is we're sourcing all of the data in a software automation, and then the risk factor data will be pushed in and provide evidence-based solution recommendations. So for example, you know, trying to address some of those workforce issues because we can get ahead of the problems a little bit. And so obviously reducing the risks altogether, and then hopefully those rates. So I mentioned that because, you know, if there are data sources that we don't have, that we're not pulling in, that you know about, we would love to kind of, you know, source that.
We can talk offline, absolutely.
Yeah, thank you.
So, you know, we're going to be heading into a new year in just a few weeks. Oh, God. Oh, God. Right? 3 weeks, 4 weeks, something like that. So I'm always looking ahead, always looking, well, how can we improve? How can the participants in this group get the most out of it? I mean, there's nothing worse than coming to a meeting and all we did was talk about the problems that exist, but we didn't try to come up with any solutions. I'm a very solution-oriented, goal-oriented person. I want to come up with solutions and I want to be of help, right? You guys are the angels on the ground out there every day doing what you do. I mean, if these organizations and the hospitals didn't exist in the county health department, just think of the mess that we would be in, and no other countries are in a mess like that. So I appreciate what you do and I want to be able to help. So a while back, pre-pandemic, we used to break up into like work groups. But then I said, no, I'm not going to call them work groups because that has a negative connotation, because I really don't want people to have to do extra work. You have your own jobs. You don't want to come here and have to do extra work. So I said, let me call these core clusters. So I call them core clusters, right? So we had one on food access. We had one on physical activity. We had one on data needs, right? And housing, I think we did have one on housing. And what I was trying to do, and I don't know if it even can still be done, but I was trying to, based upon the individuals, right, maybe 4 or 5 people in a cluster who would work intensely on this through our direction and our administrative support and everything else, is find a way to first gather data, even if we looked at select zip codes, right? So how many pantries or how many pantries are operating in such and such a zip code, and how many SNAP benefits are being utilized in such and such a zip code. And find this information out from a variety of data sources, which, by the way, is not that easy to do. I went down quite a number of rabbit holes trying to do this for food insecurity. I spoke to Hunger Solutions. I spoke to the New York State Department of Agriculture. I mean, I chased it down, and I was just trying in just one zip code. It was just Wyandanch that we thought we'd work with, right, to start. We could not seem to find, and I don't know if it was because, I just don't know what the problem was. And it was like 4 people working on it. And I had a data analyst at the time who kept doing these heat map after heat map after heat map to show where the pantries are and where the SNAP benefits are being provided and what agencies are doing what. And it was such a tremendous effort to get this done. And the reason why we were doing it is because we were trying to meet that holy grail of, you put interventions in place, you want to see what happened, did it make a difference, right? We wanted to see what was the SNAP usage, and we could look back in time, right? We could look back a couple of years ago. What was the SNAP usage at, I don't know, 2010, whatever. Now what's the SNAP usage in that area in 2015? That you could find relatively easy, but we wanted to also look at other metrics like the EB, the SNAP benefits. What food institutions had the ability to take and utilize the EBT? We found in Wyandanch that there's, as you know the area, there's one major food market there. It kept saying no redemptions, and it completely boggled our mind. It took us months to finally, I think we found the answer out through somebody at the state level, that there were new machines, or something happened with their EBT machine that it couldn't read the cards, and so they just weren't utilizing the patron's EBT. It was bizarre. It was bizarre. So this is, it's very time consuming, right? It's, I think a lot of people don't realize behind the programs, all those little steps and those little snafus you come up against that don't make it run as smoothly as it should. My feeling is always, there's always a way around obstacles, right? I always try and find a way around obstacles. So we worked very hard. We had the Cornell Cooperative Extension, we had the Curating Healthy Schools and Communities grant, right? Whoever was working in that community, we wanted to find out, what's your data, what do you have? Well, some had no data, some only had some handwritten scratched data, like, oh, we handed out 50 extra food bucks. Well, how many we used? Well, we don't know. Like, it was very, so, and Wendy touched upon this, like, a good way to track data and handwriting it is fine, right? As long as you're fastidious about it and you follow through. And so I have always tried to tell everyone that data that comes out is only as good as data comes in. So when you are designing your programs, think about that. Like, what are you measuring? And you need to show success, right? If you have a funder and you want to go back to them, you want to say, look, it worked. Or maybe it didn't work, so we tweaked it along the way. You got to really think about that evaluation part of it way at the beginning so that you're not scrambling, which is often the case, to find the data. Oh, well, how many of, vaccines did we? Well, vaccines is not a good one because you definitely had to keep track of that. But how many, how many food baskets did we hand out, or whatever it is, right? Or if it's in the case of trying to teach people about diet and exercise, well, it's not enough to just tell them about it, right? First of all, you have to make it as simple as possible. Ask them, get a baseline if you have a program that you're instituting. Where do you exercise? How often do you? A few questions. 5 times a week, 1 time a week. And then after this 6-week program or whatever it is that you're holding, ask them the same thing again. It's not that you've done this, you're not doing regression analysis and chi-squares and all of that epidemiological.
Let's go a quick question.
Yep.
So again, when it comes to the exercise for the hospital systems, I work at a level 1 trauma center.
Yeah.
And the leading cause of hospital admissions are due to falls. And that's nationally when we track the data from our registry nationwide. So all the trauma centers have to offer evidence-based fall prevention programs. And the 3 big ones are stepping on, matter of balance, and Tai Chi for fall prevention and arthritis.
Come with their
And the
own.
biggest problem I'm having, because I do geospatial heat mapping to track all this data, and it takes years to really quantify and show the results. But if anybody in the room has a connection with Office of Aging, I can get people certified to be facilitators to teach this course for free. And it normally would be a pretty high cost. But the thing is, I could only teach so many classes myself. But if we can get more people trained to teach these classes throughout Long Island in libraries, senior centers, or even some of the 55 and over communities, we would then have so much more data. And I have the pre and post surveys, which I can send you offline if you need. But I'd love to see if we can collaborate with some people, get more people trained and really bring these programs out there. And we're glad to speak with anybody after the meeting or down the road to talk about the work we're doing.
Yes, so getting back to my point about core clusters, I realize I went off on a tangent again. I do that. I get so passionate about this. Falls prevention could be a cluster in and of itself. Fall and accident prevention, right? And then a group who are interested in that could work on a project or select an area to show over time the changes or the improvements in reducing falls. And you can then look at ED data, right? You can look at the ED discharge data or the intake data as well, right? So who's there for a fall? If a lot of 50% were there with fall, and now 2 years later it's gone down to 48%. Well, can you specifically say it's because of your falls program? No, but you can indirectly make an extrapolation that education had to have something to do with it, and you can kind of count that as a success. And that's kind of this collective success that we all work on. So that's a great example of so my point being is, should we resurrect these clusters? I guess that's the point I'm trying to get to.
It would be great.
Yeah.
Yes.
I agree. Okay, so so falls, physical activity, injuries, right, is one. I think mental health, mental behavioral health is another.
Chronic disease.
Chronic disease.
I think the food security, I mean, I think we still need to have that.
Food
and
insecurity, yep.
Should we do anything with maternal?
Maternal,
since
we can.
It's so much money being spent.
So much, yes, and then there's
then-
probably a lot of reports and data that we could latch onto. So if you want to do that, we're happy to do that, and
Aging, sorry to interrupt. As you
aging,
mentioned,
right, and they
so-
have the whole
And that
aging
can
plan.
be a part of this,
Yeah.
for prevention.
Yeah, yes, the whole aging. So if you want to do this, and this is what the collaborative did pre-COVID, right? So when COVID happened, we all know what happened. We all had to go crazy and do what we had to do. We, as the collaborative, would be more than happy and willing to direct these clusters, provide the infrastructure support, right? Could be Zoom meetings, but you gotta think about, is there a project, or is it there like a couple of zip codes you want to look at? Like, kind of think about that. So what we'll do is, we heard from you. In our follow-up notes, we'll note these topics and maybe put a line or two about where we think you might be able to go, right? Because you don't want to work on a project or in a committee that never comes to a conclusion and gets anything done. Because that's no good. That doesn't make any sense. So that's good. So that's good to hear. All right. So we'll go on to the next.
Speaking of interventions.
Speaking of interventions, you want to take this, Brooke? Oh, but we can't see.
Yeah, they
the
can't
thing.
really see me, so
But that's all right. They can hear you.
take it away.
He doesn't want me to, okay. Okay. So one of the things the collaborative has been able to do with no funding is to continue to use our, like I said, we have this unique combination of public health, communications, and marketing skills, is to use that to design awareness campaigns. And one is completely around preventing chronic disease, right? And we put together a video of a gentleman who went through, and you've probably seen this. It's old now, but it's still timely and appropriate. Who went through the National Diabetes Management Program, worked with the County of Suffolk, that was the partner, and was able to, he was pre-diabetic, so he was able to come off all medication, lost weight, all of it, and he gave a testimonial for a first-person account of the success of it, and then we had the program director also speak. And then we tied that into, we call that the Live Better campaign, that there are options and programs and resources for you out there, much more so now because of how the internet exploded with online assistance, that you can use to better manage your chronic disease if you had one, or prevent one from even, one even starting if you eat right and exercise. Not that that's always going to be fail-safe, but it's better than doing nothing. So we thought we would resurrect that because we already have that in place. And again, all materials are packaged for you. You can use them, you can co-brand them, you can, whatever you want to do. You need us to put together some slides that you might want to go around. You're signing off by Sloan. Do presentations, whatever it is. Okay. So that's what we want to do. Thank you. Great meeting. Bye, Erica. Yeah, we're coming up on 11:30. And then we thought we would do a new campaign, island-wide, right, that we would design here with everyone's input that was specifically to that second priority that the group agreed upon by consensus from the prevention agenda. Promote well-being and prevent mental and substance use disorders. We thought we would do that. I don't know if you think that's a good idea. We certainly probably the mental health core cluster, that probably could be what you do with our assistance. And we can get that going. All right. Any idea? I don't know if anybody else has any ideas. I think I'm yakking too much. What's next? Okay, so we're going into 2023. There's a lot I always want to do, but not enough help, but we do it somehow. We got to streamline this collaborative website. I know you go on there, so she told me, I can't remember her name. Oh, what was her name? Teresa.
Amy?
Oh,
Right next to you?
yeah.
Amy?
Amy said it's great. She goes on the website, she gets the data. Okay. It's a little hard to find the data right now on our website. I'll be honest. It's not the easiest to navigate. So Brooke and I are not webmasters, but we do have enough knowledge that we think we can go in and clean it up a little bit. So that's what we definitely want to do. Okay. I paid it forward with the company that is our overseeing our website right now. Just really, oh, you gotta hit the, oh, I'm sorry. I'm just gonna doing updates. I don't know if it's gonna let you.
Yeah, I don't know.
All right, I'll go fast. So we're gonna, her website, the contract ends in 2023, and really they just hold the, security certificate. They don't really, I couldn't go to them and ask them to streamline it because all I really paid for was the certificate to keep it in place till 2023. So when 2023 ends, we're gonna have to pull this website in-house or find another vendor with.
I got somebody for you.
Okay, with reasonable charge that I can go to. And so that's where we're at. Do we have any other slides, Brooke? Or was that it? Just reminders. Quick reminders. We have the collaborative communications, right? So all these great programs, if you don't tell people that you have them and get it out there, it's useless. So we have over 400 contacts. Every 2 weeks we send this out. You can submit your events, your resources, jobs, send it to Brooke. Be sure to subscribe to collaborative communications if you haven't already. And that's a resource for you. We also have a Walk with a Doc chapter here on Long Island, and we've worked with a variety of partners, AARP, Stony Brook, who else? Evolve Fit Wellness, a number of groups to hold these Walk with the Docs in the community. We get a doctor, usually from one of the hospitals, who comes, gives a few minutes, talks about the benefits of walking, obviously, for health reasons, and then leads the individuals on a walk. So we used to hold those regularly the last Sunday of every month. COVID came, couldn't do it anymore, so they've been a little bit more sporadic, but we're always happy to partner. We do all the promotion, we put the whole thing together, and it's handed to you in a ready-made platter. You just have to help promote it, right? So that we get people there. And we've done this with AARP as well. And then the talk with the doc, that we did with AARP, where we did a webinar series. And then it culminated in 2 walks. One in Jones Beach and in the summer, and one in, I don't know.
Belmont.
She had COVID for both of them. So I had
the
to
worst
do it
timing.
I had to do it by myself in the blasting heat in Belmont, yeah. So that's what we did, you know, so, and we then collect data out of all this. We have a pre and a post survey we hand out. And we collect that data and then we make that data available to you. Now, I'm not gonna say, oh, you got hundreds and hundreds of people. It's not, but it's all relative, right? It's some data. It's better than no data. And then here's the upcoming meeting dates. Maybe we'll stay hybrid. Maybe everybody just wants to be in person again. I'm not sure. What are those on the call think who are left? What do you think? Do you feel like you missed out because you weren't here in the room with us? Oh, hybrid, John, hybrid. Well, let's take a quick vote around the room here. We could do like 2 hybrid, 2 in person. We could do 3 hybrid, 1 in person. Let's take who's for hybrid? Raise your hand.
I like the option.
Hybrid
is
pretty unanimous.
There it is, hybrid. It'll be hybrid. It's hybrid from here on in. It makes our life easier. We will get much better at the equipment. And I guess that's it. I wish everyone a happy holiday, whatever it is that you celebrate. And certainly wish you a happy and healthy new year. I wish an end to all these viruses. And really want to see everyone. Thank you so much.
Awesome.
I hope
Yeah,
it's
well,
everywhere.